Thank you so much, Jim. I see I already have 3 people who have raised their hands, so I'm going to just quickly go and call for their names. I have Kioma, if I'm pronouncing that right. So if you could just unmute your microphone and ask your question, please. And who's your question to specifically as well?
Hi there. Do you hear me?
Yes, we do.
Perfect. This is for Dr. Linda Gray. My wife has been having rebound high pressure for about 8 months after a 2-year leak, but we live at a really high altitude. Is it possible that it makes any difference, the altitude you're living at? We're about 8,500 feet.
Yeah, definitely. It definitely makes a difference. I've had patients who have come from Colorado and, with terrible headaches, and sometimes people just don't even think of altitude as a cause of a high pressure headache, but absolutely, elevation can definitely affect it. And the way you might be able to sort that out is to just go to the sea, go someplace along the coast and see if her headaches don't improve. But rebound high pressure in conjunction with high altitude, that's going to be tough to manage. But yeah, definitely can happen.
Thank you so much, Dr. Gray. The second person is Jolene Hendron. Jolene, please go ahead and ask your question. You will have to unmute your mic first. Thanks.
Okay, thank you. Just wanted to say thank you to all the presenters. This information is very valuable. I live in St. John's, Newfoundland, and have been suffering with a CSF leak or a suspected CSF leak for 3 years. For just over 3 years. I've really had to advocate for myself to try and educate my neurologist on next best tests and next steps, but I'm not really getting a lot of momentum. We have looked into traveling to Duke. I guess I have, Dr. Gray, I'd be interested in knowing if you guys are accepting international patients at this time. And as well to Dr. Peng and maybe Dr. Amoozegar. I am interested in, I appreciate the challenges that you guys face here in Canada, and I'm wondering if there are any circumstances under which you would accept a referral from out of province.
Who wants to start? Hi, Wouter.
I may start.
You're on mute.
So, here go. Can you hear me? I think I unmute already. Good. So right now, just looking after the patient from Ontario, we have quite a limited capacity. So we usually accept referral when you have a support from the neurologist and have a good workup, because it's very difficult for you to come and stay in Ontario and have a number of different workups. So it would be very, very difficult to get all these resources. The other things I would like to ask Linda, during this COVID, we do have some difficulty getting patients across the border. And how do you manage? So if, say, this patient from Newfoundland want to, or St. John want to refer to you, how do you manage then? Because our borders are not fully open during this COVID. Something that is new, and I find from a few patients that have some difficulty crossing the border.
Right. I think that's opened up now. We have an international office that deals with everybody who comes from out of the country. I would just caution you about coming to the States right now because COVID is really on the rise. I think I'd rather go to Canada. I think your guys' numbers are better than ours. But we are definitely taking patients and really the amount of COVID that we have around Duke and in our area in North Carolina, although the numbers are rising, are not as bad as some areas of the country. But we have seen some international patients now. We weren't taking any for a while, but we have been taking some, yes. Then you can go through the international office in order to, you have to set up a medical record number, and then we can start looking at your imaging because you'll have a Duke medical record number that we can load all the images on our PAC system and see if we can't start to help.
So I just want to respond to the one who asked the questions. All Canadians, so we will look after our own fellow Canadians. So I'm not here to say I'm going to reject your referral. Just hope that you can get some help from your fellow physician to at least to have some scan, to have some initial consultation from neurologist. So we don't have to start everything from just like we are from zero. We take outside referral from time to time based on the circumstances. So, and the other thing is, yes, you can ask your family physician to get the paperwork to refer to Duke. And I have to say, yes, there is another consideration now because of the COVID. Yes, Linda have a very honest statement. We are much safer in US in terms of this. So something for you to consider.
One other additional thing I wanted to add is that, it's difficult perhaps to see patients from different provinces in Canada, but one of the things that we're certainly open to doing and are able to do more easily would be to have a consultation with the family doctor or neurologist that's at the local location. So, for example, where you are at for the patient that asked the question, we can review the images, which can be sent over electronically or by disc if necessary, and also provide some guidance in terms of next steps for workup and management. So at least that, there's a path forward. So we can certainly offer that as well.
Thanks, Dr. Pang, Dr. Gray, and Dr. Amoozegar. The next person here is Carolina. Carolina, if you could unmute yourself and ask your question, please.
Hi. Thank you so much for this opportunity. I'm so happy to be here and very thankful for all the kind information and very important information for us. Well, actually, my question will be to Dr. Linda Gray. I think maybe I'm from Switzerland, so I think maybe you remember me. We have been in touch with some emails.
Yes.
So I am wondering about this circumferential patch you were talking about. I'm very interested to know how you perform that. How much blood do you inject? It is fibrin or is just blood, and how is it done? And if is this done mainly as a technique after, for example, lumbar puncture that doesn't really heal? That's something that I had never heard before, and I am very interested to know about this. Maybe just to profit from this space, I kind of want to know if there are some difference reported in the symptoms of people that have venous fistulas and other type of leak, like if it's different, some of the symptoms reported between people that have venous fistulas and other type of leaks. Thank you.
Well, I think that, okay, so let me start backwards then, okay? So people with CSF venofistulas as opposed to other leaks, I don't know, sometimes I feel like the imaging studies, it depends on, we don't really know where the fistulas come from exactly, like what causes them. Some of the patients are actually high pressure people who may blow out into a fistula. That's one of my theories anyway. And so some of those people may not be quite as symptomatic, and they won't have as much in terms of sagging brain, if that happens to be the etiology. Some people with fistulas have really terrible sagging brain and are really terribly symptomatic. It seems like some of the discs, if they've been going on for a long time, the patients who have normal looking brain scans actually, it may be that they sort of develop kind of a pseudomeningocele, which is ventral to the sac, and maybe they kind of balance out ultimately so that they just aren't quite as symptomatic. So, there's so many different components that might contribute to, how symptomatic you are, and whether you're a high pressure person who blew out or whether you were just low pressure to, you just became a low pressure person. So I don't have I don't know. I think in general, I think CSF venofistula patients tend to be more symptomatic, and they're sometimes harder. To find the fistulas is harder. The second question about doing the circumferential patches, they're super easy to do. You just do them transforaminally, but you have to do it under CT guidance in order to make sure that you're actually getting the blood and fibrin glue around the thecal sac. And you do that by first putting in the contrast and noting that the contrast is going around the thecal sac. And the amount of volume that you put in really depends on the size of the spinal canal. So you want to try and get it to go all the way around. So you may put in 10 or 20 cc's of blood and or fibrin glue, depending on how big that spinal canal is and how big the epidural space is. But yeah, you can do it under CT guidance and it's pretty straightforward. So that's, I think, the first question. Did I get them all? Any other question that I needed to answer from you? Okay.
I think, yeah, I think that answered her question. The next person is Pierre Bergeron. If you could unmute your mic and ask your question, please.
Yeah, hello. You could call me Peter. It's going to be simpler. Okay, I'm addressing, let's say, just during the COVID period, exactly what Dr. Amoozegar have said. I need a second view of my scans because I'm a 3 years SIH diagnosed. So I'm addressing this question to other than Dr. Amoozegar that already answered it. But is it possible to have a second view of scans? I have plenty of them with all the techniques. Maybe that they are not perfect, but I think they are good images. So is there any way to have this service, as particularly during the COVID, as to have a look? And Dr. Shivink and Dr. Gray, if you could answer also, I'd be pleased.
Wouter, you want to answer that? You're muted. You're muted. You have to unmute yourself.
Shall wait. Yes, we're always happy to look at any scans. We'll just email you a link and you can upload them yourself. You don't have to physically go to a post office or something. So that has made it, very, very easy to do. I mean, it might be a while before you actually get an answer back, but.
Yeah, and all we require is just that you get a medical record number. So you can sign up with the international office. There's no charge. And then if you just send your scans in, we'll have them uploaded and we'll take a look at them. So yeah, we'll be happy to take a look at the images.
Many thanks.
Perfect. The next participant who has a question is Dr. Lucchese. Did I pronounce it right?
Yeah, it's really good. I don't think I put my just call Scott. Scott is fine. The CSF leaks have turned out to be the most fun I've had in medicine ever. Once I finally got somebody that would help me work on them. It took probably 8 years to get anybody that was willing to work on the patches. But I'm a neurologist, so I don't get to stick needles in the spine and stuff, which I wish I could, but I don't have time to learn all that at this point. I'm too busy. What I'm really interested in is a diagnostic approach, and I found a few things that are interesting, but one I've been trying to do, and I can't get anybody to help me with it. I came real close, and then COVID happened. Has anybody tried taking these folks up in an airplane to about 5,800 feet and see if they feel better? That's normal pressurization for most domestic flights. I mean, you go to 5,800 or 7,500 feet, and a lot of the patients, they may improve because they tend to have improvement during air flight. Has anybody heard of this being done, or some kind of application, maybe bariatric chamber? Because it'd be nice to have a screening test.
That is a super interesting idea. We actually have a barometric pressure chamber at Duke. And we have thought about doing that, changing the pressure and seeing what happens with the patients. Our barometric, it costs $300 an hour to put somebody in a barometric pressure chamber. I don't know, that probably is cheaper than some air flights. I'm not sure it's cheaper than driving to the mountains, which would be another way to manage that possibly, have somebody drive up to the mountains, go to, 5,000 or 8,000 feet and see if they feel better. Most of the high pressure people will feel absolutely worse. and the low pressure people do tend to feel better. So I think it's a perfectly reasonable approach.
Yeah, that we have a bariatric chamber too, and they're kind of interested in it, but I'm behind on my IRB training, so I haven't been able to get an IRB written or try to get any money for it yet.
Yeah, but it's an interesting thought.
Yeah, so
Especially if you don't see anything and, the patients are symptomatic. And I wonder, what would happen with people with POTS who just had POTS if you put them in a barometric pressure chamber too. Be interesting to know what would happen with those patients as well.
Well, I'll tell you just briefly, I had a patient, I couldn't find anything in the spinal imaging, but she had definitely saggy brain, not horrible, but maybe 2 millimeters tonsillar ectopia. And COVID happened. I couldn't do anything. So I told her, okay, just try an abdominal binder. And most of them may or may not try it. She tried it. And I didn't see her for like 2 months. And then I did a telehealth visit, because I started up again. And she said, oh, yeah, I don't have headaches anymore. So I said, well, what did you do? Because, I don't know. Well, she thought the abdominal binder helped, but it wasn't good enough. So she went to some costume store and got a bone corset and wore that for like the whole time. And then she started getting frontal headaches and stopped wearing it. She didn't have headaches at all anymore. That's been a few weeks since I've talked to her, but I don't know what she fixed. But she was better, and it seems durable at this point, so I don't know.
Maybe that'll be a new treatment.
Yeah, I probably need to write a case report, but I don't know where to publish it. So. But anyway, that's what I was wondering about.
Yeah.
Thanks, Dr. Lucchese. Dr. Gray, it's interesting you brought up that topic of POTS. There was a recent study which was published in a physiology journal, and it was based out of a basic science research group from Netherlands, but the study was funded by NASA, and NASA astronauts actually who stay in the International Space Stations for longer periods, they have similar symptoms. A lot of them have reported over a period of time where they get postural hypotension, orthostatic headaches kind of features. And that study looked at how gravity and postural changes have an effect on the cerebral perfusion pressure and what's the dynamics is with respect to the arterial pressure of the brain and the intracranial pressure. So a pretty interesting study on how the homeostatic mechanism, the sympathetic and the parasympathetic regulates all that, which could probably play a great role in patients with POTS and their headaches to kind of determine the etiology.
That's a whole nother area to look at. Be super interesting.
I have a couple of people. I have Betty Edwards here. Betty, please go ahead and ask your question, please.
Hi, Dr. Shavink and Dr. Pang. I actually seen you in 2012. You probably don't remember me.
Hi, Betty.
I'm from Canada, and I kind of asked this question, but didn't quite get it out right. And I wanted to know, I have had 2 blood patches. I started leaking in 2010, so there really wasn't a lot of information then. And I had 2 blood patches in 2010. And then I went to see Dr. Shavink and had cervical surgery. And then I went back to Dr. Shavink and he couldn't find anything with the MRI. So we did a 2-level 37 mil volume blood patch. And I didn't, no rebound high pressure. The only thing I got was sore legs. And then I went to Dr. Krantz, and Dr. Krantz did glue and blood at 9, 10, and 11. And I went into the worst headache I ever had, worse than low pressure. It was off the charts, like at 3 o'clock in the middle of the night. And then I've since bounced around. That was in 2018 with Dr. Krantz. And I probably feel, I mean, I still have to lay down on occasion, but I am upright 90% of the time. So would that be indicative that maybe the 9, 10, 11, along with the cervical surgery, would have actually found the second leak? And actually, Dr. Shavink, you've always told me that you thought I had a second leak.
Well, it's certainly suspicious, I think. I mean, it's hard to prove it one way or the other, but I'm glad to hear you're feeling better.
But if you were to have a glue and blood patch, Would you get rebound high pressure?
Well, it would depend on who would do it. Like if Dr. Gray or Dr. Kranz would do it, would definitely get a high pressure headache.
Oh, here he goes. It's always joking with me.
No, but if it's somebody, who does a 10 cc blood patch, then that probably wouldn't make any difference.
So having a 37 cc in California, and I didn't get any headache at all, and then having 6 mil between the blood and the glue at Duke, I had horrible rebound high pressure. Do you think that would be indicative that maybe the second leak was found?
Yeah, certainly it's suspicious for that, or it could be some cumulative effect. It's hard to know. But I definitely think that getting, rebound high pressure type of headaches after a blood patch, does not necessarily prove that somebody had low pressure, right? Because, we do blood patches on patients who I think really don't have a leak. And I'd say the vast majority of those get a high pressure headache.
Yeah, yuck. That's not the answer I was looking for. But I have been upright, like I say, 90% more than I was probably the last time I seen you, Dr. Schvink.
Yeah.
So since 2010, I'll take it.
Good that you're feeling better.
Yeah. Thank Dr. Krantz for me. I haven't talked to him, but
I sure will.
All right. Thanks, Betty. Thanks so much for your question. I have another participant here, Anne. Please go ahead and ask your question.
Hi, this question is for Dr. Pang. So, Dr. Pang, I think you were recently made aware of a foundation in the US who is about to embark on research using a 7T MRI focused on a range of potential symptom mechanisms such as structural abnormalities like Chiari or occult tethered cord, neuroinflammation related markers, autonomic dysfunction, vagus nerve issues, blood and CSF flow dynamics, intracranial pressure evidence, and metabolic impairment. Do you feel that there may be benefit in exploring these mechanisms in terms of diagnosing and treating CSF leaks?
Well, the two comment on this. One thing is that in the last 5 years, I think that the expert in SIH probably know that the more we know, the more we don't know. So we are exploring a lot of information. So yes, we are always anxious. But the second is the question you're asking me is almost like you ask a teenager, is it good to compete with Usain Bolt in the next Olympic? So we don't even have a program. So in US, it's quite easy. Well, you have a program. In Canada, we don't even have a program. Not just we don't even have a program, you don't have a lot of different here and there. Well, if in my talk, I mentioned that I love to have more resources in infrastructure and a program, and we have a CSF Canada Foundation. We hope we have all this, and finally we will get something that high end to get all this. I think if you ask a poor person, that's what he need a house, he need something to eat or drink, but not a Ferrari. So this is actually the direct answer to you.
Thank you.
Thanks, Dr. Pang. I have 2 or 3 more questions, and in the interest of time, I'll just quickly go ahead. Julia, do you have a question? Please unmute yourself and ask your question.
Hi, yeah, I'm wondering, I think this is for anyone, maybe Dr. Schvink or Dr. Gray. I know I've been told that dural ectasia is a reason that perhaps people could have a transient benefit from blood patching. I'm wondering what the duration would be of kind of like how long could someone have relief before you'd start to think this is more than just dural ectasia, this is more confirming that there's a leak? Like for instance, if someone's improved for like a month after a patch, would you say that could be from something other than a leak?
Well, I think that's a really good question. And when we wrote the ICHD3 criteria, we struggled with that a little bit, because in the second iteration, there was one of the criteria was response to epidural blood patching. We decided not to put that in there, mainly because it's so subjective. the way that we'd like to practice is try to be very practical. And I think if we do a blood patch on somebody and they feel great for months, then, it's hard to say, well, maybe this was a placebo response. Some patients will tell me, oh yeah, I felt great after blood patching for like 10 seconds while I was lying down. I think that's, that's more difficult to really put your finger on that. I think patients with dural ectasia, for example, the whole Marfan patient population who would fit criteria because they might have very low opening pressure. But in those patients, you oftentimes don't really find a leak. You just find this very capacious, dural sac. And it's really more of a pooling type of mechanism. But still, most of those patients get really good benefit from repeated blood patching. And if that, and if you see a patient who have benefited from that, then sometimes we do surgery. Sometimes we do this dural reduction surgery, but in patients who have a good amount of dural ectasia, that's really, really tricky because the dura is so, paper thin. And with each suture, you just cause more tearing. So then I just place artificial dura over the area of dural ectasia. And that seems to work really well. Although even that can have difficulties as well. I did that kind of surgery on a young woman from Boston with Marfan syndrome, and there was no leaking during surgery. I just placed that dural graft or post-op MRI looked great. And then 2 months later, she called us because she had developed a giant pseudomeningocele at the site of the surgery. So it's really hard to understand how that happened. Luckily, that just resolved by itself. But yeah, the whole dural ectasia is, I think it's different from, a typical, spinal fluid leak.
And
the
only other reason that someone would improve after a patch aside from having a leak?
Well, it's either a leak or it could be, the patching causes scarring, causes inflammation over the dura, and it will somehow affect the elasticity, or rather the elastance of the dura, and that certainly can be enough to ameliorate the symptoms. So it doesn't necessarily mean that it's a leak, right? If you get better after a blood patch.
Yeah.
I mean, not even talking about placebo effects, but just by virtue of the of dural ectasia, you can benefit from blood patching without actually having a spinal fluid leak.
Because you probably reduce in some way just the overall volume of the thecal sac itself. So you don't know what contribution just reducing the volume of the CSF space might be when you're putting in that patch. So
Right.
you can definitely reduce that.
What imaging would show dural ectasia?
Just an MRI scan is great.
Okay. Great. Thank you so much.
You're welcome.
Thanks, Dr. Shivenka. I see the question.
Okay, thank you so much. Dr. Gray, thanks for addressing Chiari. So let's say you do have those low pressure symptoms and you get a Chiari surgery anyway, and then all those low pressure symptoms do go away and then they come back, within 3 months. And so clearly it could be a leak. I'm wondering, could it also be something else like scarring around the surgery site? I've had a second Chiari decompression.
Yeah.
Went away for a month, went away 3 months for the first time, 1 month for the second. And, for the last 3 years have had, these low pressure pulling pretty, relentlessly all the time, except for the morning. Morning, I'm actually really good and it just gets worse during the day.
Yeah, I mean, Wouter can also weigh in on this because I don't do these surgeries, but I do know that people after surgery for Chiari can have scarring back there. Sometimes you have to actually open up that space and put in a dural patch. So sometimes that happens. We have had people who develop pseudomeningoceles after that, but I'm presuming that, they ruled that out in your case.
Yes,
Yeah, I think in general, you want to think of everything else, and then Chiari is the diagnosis of exclusion. You think of high pressure, low pressure, and then is it a Chiari? If you have a small posterior fossa too, that can kind of help. And then I pointed out that incisional line, which can maybe be helpful in terms of where the opening to the aqueduct is in terms of that. That can maybe be helpful too. But
yeah, I got to go back and have my doctors look at that for sure. Yeah.
Yeah. But Wouter, maybe you've done some Chiari decompressions, or maybe you send those out. So
no, we do quite a bit of Chiari decompressions, and some of those patients do turn out to have a spinal fluid leak, of course. But one of the issues is, so most of the time we open the dura, right? We open it all up. Not always. Sometimes you just do the bony decompression, but usually you open up the dura, and then just by virtue of surgery, you'll usually spill a little bit of blood within the spinal fluid. Or if you suture in a patch that's not from your own tissue, like a pericranial patch, you can get something that's called aseptic meningitis, which is
I had that.
Yeah, so just by virtue of having debris in your spinal fluid, that can really plug up the normal absorption pathways of spinal fluid. So that's how I think sometimes people who we know have a leak get better after a Chiari decompression. And some patients after a Chiari decompression, even from a real Chiari, go into high pressure after they develop this aseptic meningitis. I mean, it's easily treatable with steroids. People will fine after a while, but it can cause permanent problems with CSF absorption.
Okay, thank you. I'm not sure what to do with that, but thank you very much.
Now, I'm going to ask you one last question. Now that we are talking about Chiari and CSF leaks, I had a patient, a 15-year-old, who developed severe body pains, myalgias, and it eventually became bed-bound. She was found to have a 14 millimeters of Chiari, but it was not thought of as something that was causing or was contributing to her presentation. Finally, she got someone to operate herself and completely resolve the symptoms for the next 5 or 6 years. Very high functioning individual. And now I've been seeing her for the last 6 months. I can see again that her symptoms are following the same trajectory. And she's just not compensating very well at this time. And there's a residual Chiari of 7 millimeters. We did the somatosensory evoked potentials and brainstem auditory responses, came back as normal. And now we just don't know what to do. Is there some sort of, we also did the MRI with GAD enhanced. It's not showing any leaks per se. Her posterior foci is not small. We just don't know where do we go from here? Is there some imaging which we should do to identify what's happening, or what would be the treatments if you could recommend that, both Dr. Gray and Dr. Schwenk?
Well, I think it's difficult, right? So in teenagers, you see a lot of teenagers who have a Chiari with or without symptoms, but oftentimes that will resolve with time, right? As they grow older, a lot of Chiari malformations will just resolve just by, as a product of normal aging in teenagers. The other thing is, so if somebody had a 14 millimeter Chiari and now it's a 7 millimeter Chiari, unless they resected the tonsils, which still some neurosurgeons do. So usually the Chiari itself doesn't really change after surgery, right? You just make more room for spinal fluid around that part of the cerebellum. So that sort of makes me feel like, well, maybe it's from a spinal fluid leak if it really went from 14 to 7. But also after surgery, it's more difficult to measure, right? So because because of the craniectomy. So oftentimes it's kind of hard to measure, or they'll not measure it, in the exact mid-sagittal plane, but perimedian. That can cause changes in how it's measured. But I think, usually I don't like CSF flow studies for Chiaris. I don't think it's that useful. But in this situation, where there might be scarring, there might be ptosis of the cerebellum, it might be of some use.
Yeah. I usually don't suggest CSF flow studies, but I agree with you. In this case, it might be helpful.
Yeah.
If you've got scarring and stuff.
Thank you so much. Yeah, I'll have to find someone who could do the science studies in Canada here. All right.
Dr. Peng, he'd be happy to do it.
Yeah, I'm gonna send it to Dr. Farb and Dr. Pang's team. Okay, all righty. I think we are quite like reaching 12:40. So thank you so much, everyone, all the physicians on the panel here and the participants as well for making time and being with us here today for the first session.